Hello and welcome back to Zoology 141 Online. Today's lecture will be on the integumentary system, which involves skin and also hair and accessory structures. So after completing today's lecture, you should be able to describe which tissues are present in skin. You should also know the major functions of skin. You should be able to distinguish the layers of the epidermis and the dermis and know both the tissues that are involved in these layers as well as the function of each layer. You should also be able to describe the differences between thick and thin skin and tell me where they're found on the body. In today's lecture, we're also going to review the structure and function of certain accessory structures that are associated with the skin, for example, the fingernails, hair, and sebaceous glands. And finally, for the last part of the lecture, we're going to briefly describe how the skin repairs itself. So first of all, let's take a look at the functions of skin. The skin is the largest single organ in the body, and it has many important functions. And the first of these falls into thermoregulation. That is, it helps us to maintain our body heat at the proper temperature. So, for example, when you're really hot, your skin will perspire from your eccrine sweat glands, and this will help to cool down your body temperature. The other thing that happens when you're overheated is that the capillaries or blood vessels that are in your skin will dilate, making the skin appear red, and that redness brings the blood close to the surface to help with heat exchange. On the other hand, if you're really cold, the blood vessels that are in your dermis will constrict, and they will hold the blood in the warmer parts of your body, thereby conserving body heat and preventing convective heat loss from the surface of the skin. Another important function of the skin is that it is a very large blood reservoir. The skin has lots of blood vessels, for example veins in it, that are serving as storage places for blood until it is needed. For example, during normal everyday activities, a lot of your blood is actually sitting in these veins within the skin. However, let's say you have an episode of blood loss or increased cardiac demand. During these circumstances, the blood vessels within the skin will constrict and force that blood back into primary circulation so it can feed things like your heart, your brain, and so on. Another important function of the skin is, of course, protection. The skin is the first barrier between us and the outside environment. And so the skin protects the body from a wide range of damage. For example, physical damage as a result of abrasion or UV exposure. And there's also the potential to protect us from chemical damage. Our skin is pretty chemical resistant, and it's also a very effective barrier against biological pathogens. These are things like bacteria, viruses, and even some larger bodied organisms like mites. And so if we look at the skin, we see that the epidermis has these tight cell junctions that prevent bacteria from being able to easily invade the epidermis and get down to the dermis. The other thing that we find in the skin is that there's a lot of lipid in there that is accumulated in the upper layers of the epidermis, and this lipid helps to retard or prevent evaporation of fluids. And finally, the pigments that are in the skin also help to protect us from some types of UV radiation. And you've witnessed this if you've ever tanned by being outside for a long period of time. You'll notice your complexion becomes quite a bit darker as the release of melanin from the melanocytes begins to block and shield the underlying cells from UV radiation. And of course, one of the other functions of skin is that it has some immune cells in there that are monitoring for invasion. So in case we do have an infection, the immune system will be able to mount a very effective and very quick response to that. So the last slide was just half of the functions of skin. Now we're going to go through the other half. The skin is, of course, our first and our largest sensory organ. We have cutaneous receptors all over the skin. They're particularly abundant in the fingertips and also in the feet. And so they help us to discern touch, pressure, vibration, tickle, itch, cold, hot, and various forms of pain. And we'll talk more about these receptors when we get to the nervous system. The skin also has important metabolic functions as well. For example, in order to synthesize the functional form of vitamin D, we have to have a little bit of UV radiation to activate vitamin D in order to absorb calcium. The other thing that the skin can do is it can inactivate some sorts of carcinogens and make them non-harmful. On the other hand, it can also modify some non-harmful compounds and make them into potential carcinogens. And finally, the last function of skin is excretion. We don't often think of the skin of an excretory organ like the bladder or the kidneys, but in fact it is. We excrete around 400 mils of water a day, regardless of whether you're going to the gym or not. And that water contains some salt, some gases, for example carbon dioxide, and it also contains a fair amount of ammonia and urea. And this is why if you ever, say, had a gym locker in high school where you had your gym clothes and you wouldn't take them home to wash except maybe once a semester, this is why those clothes smell really, really bad, because the urea and the ammonia that's in sweat remains in your clothes even after that sweat dries, and it's an excellent food source for some pretty yucky bacteria. And that's why gym clothes begin to smell very bad even after a short period of time. So now that we know a little bit about the functions of skin, we're going to go over the gross anatomy of skin. So skin can be divided into 3 layers, and these include the epidermis, the dermis, and the hypodermis. Now I need to point out that your textbook, and indeed most anatomy textbooks, will actually not include the hypodermis as part of the skin. And that's true. The skin is technically only comprised of the epidermis and the dermis. However, there's no other chapter where we get to talk about the hypodermis. And so in my lecture I will include the hypodermis, otherwise known as the subcutaneous layer, as a 3rd layer of the skin. But just be aware that other professors and other textbooks may split out the hypodermis and include it in another section of the body. So the top layer of the skin is called the epidermis. Remember, epi means on top and dermis here meaning skin. So the epidermis is comprised of stratified squamous epithelium. And remember that stratified meant that we had several cell layers, and that a stratified epithelium is going to be really good for protecting us from drying out or protecting our bodies from abrasion. It's not going to be very good for moving things across, such as secretion and absorption. Now, there's 4 different types of cells that we're going to talk about in the next slide, and potentially 4 or 5 different strata or layers to the epidermis. So first we're going to take a look at the cells that comprise the epidermis. The most abundant cell is something called a keratinocyte. And a keratinocyte, as the name implies, contains lots of keratin. And keratin is a very tough, waterproof protein which helps skin to maintain its structure and also prevents the underlying tissues from drying out. The second type of cell is something you've probably heard of before called a melanocyte. And melanocytes help to protect the underlying tissues from UV radiation by producing a protective pigment called melanin. The third cell is something called a tactile cell or Merkel cell. And Merkel cells have a sensory receptor function. That is, they're located very close to a sensory neuron, and they transduce information on things like pressure and vibration into nerve impulses which are carried away by sensory neurons towards the spinal cord. And finally, the 4th cell we have is something called a dendritic cell or Langerhans cells. These cells are basically sentinels that are part of our immune system, and they will grab a hold of potentially pathogenic organisms, and they will present these to our white blood cells for recognition and eventual destruction. Because remember that the skin, and indeed the epidermis, is the first barrier between us and the outside environment. So it makes a lot of sense that we basically want to have some guards out there guarding that barrier and making sure no pathogenic organisms make their way into the deeper areas of the body. Now, before we go on to talk about the strata or layers of the epidermis, I want to say a word about skin color and pigmentation. You probably already know that melanin is a very important pigment to helping protect the skin from UV radiation. And melanin is produced in melanocytes, as we'll see here in just a minute. And in fact, melanin is the only pigment that is actually made in the skin. The other 2 pigments, however, still have a role in determining the color of the skin. And so hemoglobin is the pigment that we find in red blood cells, and it has a red coloration. And so hemoglobin is important for giving certain people the red hue that they have in their face. If you look at people that are Irish or that are European ancestry and they don't have a whole lot of melanin in there, you can often see that sort of ruddy pink complexion, and that pink complexion comes from hemoglobin. Another type of color that we see in skin is something called carotene or beta carotene. And as you would imagine, this has a yellow to orange coloration, just like carrots. And we tend to see carotene most concentrated in areas of the skin that have a lot of fat associated with them. And as it turns out, one of the areas of the body that has a lot of fat in the underlying tissues is in the feet. And if you look at the bottoms of the feet, particularly in Caucasians or even Asian people, you will see a yellow to orange coloration, and this is due to the presence of keratin and the underlying fatty tissues. So your individual coloration will depend on the expression of hemoglobin as well as keratin, and of course the amount of melanin that's in your skin as well. Now, of the three pigments, melanin is the only one that actually helps to protect our cells and our tissues from UV radiation. And as you probably already know, there is a genetic difference in the production of melanin and amount of melanin in peoples throughout the world. For example, if you look at people that live in latitudes very close to the equator, they tend to be darker complected. Think about your Tongans, your Samoans, Hawaiians, and in part this is because they need a greater amount of pigment to protect their tissues from the greater incidence of UV radiation. On the other hand, if you look at people that live towards the poles, and we're thinking of Sweden and places like that, where they don't have a whole lot of incident sunshine, they tend to be very light complected because we do need a certain amount of UV radiation in order to make the functional forms of vitamin D. And of course, most peoples have this ability to adjust the pigmentation of the skin by tanning, and tanning involves, of course, our melanocytes. The melanocytes have special pigment vacuoles called melanosomes, and when they are exposed to UV radiations, these melanosomes will move out in long appendages through the membrane in the melanocyte. And eventually these melanosomes will actually get incorporated into the nearby cells, most of which are keratinocytes. And so this will cause a darkening of the skin and also reduce the amount of UV radiation which is reaching deeper layers of the skin, for example the dermis. However, you probably already know that tanning tends to be a temporary thing, that over time that tan is going to fade away, and that's because these melanosomes that are produced by the melanocytes are eventually broken down by the lysosomes, both within the melanocyte itself and also within the adjacent keratinocytes. Now, while we're talking about color, I should mention that the color of skin can be a very, very useful diagnostic tool when you're doing a physical exam on a patient. And so here are some examples of abnormal colors that we see in skin that can indicate particular conditions throughout the body. The first of these on the left-hand side of the screen is something called cyanosis. Now, if you ever had one of those big packs of crayons from Crayola, you know that cyan means blue, and so cyanosis is a blueness, usually of the fingertips, the nail beds, and also the lips. And usually it indicates some kind of defect in the circulation of blood throughout the body. It indicates areas of possible hypoxia, where we're not getting enough oxygen, and therefore we have this blue coloration. So oftentimes cyanosis can be a result of a problem with the heart. We often see cyanosis or blueness in newborns that, for example, have a patent foraminal valley, and that's just basically a hole between the left and right atria, and it allows mixing of blood, which results in cyanosis. Another type of coloration is something called erythema. Now remember, erythros in eri here means red, and so this is a redness of the skin, which usually is a result of inflammation or abrasion. Here you can see this bullseye-like rash that is characteristic of somebody that has Lyme disease. That is, they've been bitten by a tick that's transmitted the Lyme disease bacteria, resulting in a very characteristic erythema or redness. Another example of a redness of a different sort is something called hematoma. A hematoma is just a fancy way to say a bruise, and this is caused by rupture of blood vessels beneath the epithelial layer. And so what we have is a pooling of blood within the skin, and this blood eventually turns from red to blue to black to yellow and purple and all kinds of interesting colors. And it usually just indicates rupture of blood vessels, oftentimes due to trauma. Now, a more unusual type of coloration that we see in the skin is something called bronzing. Now, bronzing is a little bit of yellow-gold coloration accompanied by a lot of deep creases. And this is a particular coloration that's quite rare, but we see in people that have something called Addison's disease. And Addison's disease is just basically a lack of production of the hormone cortisol, and it causes some very characteristic conditions, including bronzing. And one famous person that was rumored to have Addison's disease was John F. Kennedy. Now, over to the right-hand side of the screen, you're probably going to see some skin coloration you've been more familiar with, and these include pallor and jaundice. Now pallor just means paleness, and so paleness means that the skin is whiter or more blanched than it normally is. Now normally the color of somebody's skin is again a mixture of those three pigments, melanin, keratin, and also hemoglobin. But when somebody doesn't have enough hemoglobin, maybe because they don't have enough blood cells, they will have a very, very pale complexion. And so take a look at the figure at the top right. At the right-hand side of the screen, you can see a figure showing the conjunctiva of 4 different patients. And the patient at the bottom right, that is patient number D, has the proper amount of pigment in the conjunctival tissue. On the other hand, go up and look at 4A. This person has very pale mucous membranes and conjunctiva, indicating that they have probably a lower number of red blood cells, or in this case, a lower amount of hemoglobin. And so pallor can be an indication there that somebody has lower than normal amounts of hemoglobin, which is an indication for anemia. And finally, the last color is one that you're probably familiar with, which is jaundice. Jaundice is just a yellowness of the skin, the mucous membranes, and also the whites or sclera of the eyes. And jaundice is most often caused by liver problems. And so if we have somebody that's, let's say, that is an alcoholic that has cirrhosis, or somebody that has hepatitis, if they have severe liver damage, then they won't be able to process the compound bilirubin. As a result, this yellow coloration will tend to accumulate in the skin and also in the whites of the eyes. Here's a couple more pigmentation disorders that you're probably familiar with. The first one is albinism. Albinism is a complete inability to synthesize the compound melanin. And remember, melanin was the compound that helped to protect our skin from UV radiation. And so people that are true albinos will have pretty much white hair, white eyebrows, and things like that. There will be no pigment in the skin or in the hair or other parts of the body. Another type of disorder is something called vitiligo. Vitiligo is the partial or complete loss of melanocytes within areas of the skin. We tend to see it in African Americans, particularly in the American South. Now, we don't know precisely what the cause of vitiligo is, but we do suspect that it's caused by an autoimmune response, that is, where the human body is literally attacking its own melanocytes. Okay, now we're going to go talk about the 5 layers or strata of the epidermis, and these include the stratum corneum, the stratum lucidum, stratum granulosum, stratum spinosum, and stratum basale. So the first layer of the epidermis is called the stratum basale, or the stratum germinativum. Now this is a single layer of cells that is sitting on the basement membrane. Remember, the basement membrane is the junction between epithelial tissue above and connective tissue below. And so this is a single layer of cells that are dividing very rapidly. And this layer is called the stratum germinativum because it gives rise to all the cells that are above the stratum basale. And so this is the cell layer where new cells are created. Now, it's important to realize that when we have damage to the stratum germinativum, we can have some migration of cells to fill in that area. Let's say if you get a minor cut or something like that. But if we get a very, very large cut, let's say to over an inch of the skin, it's very unlikely that those epithelial cells will be able to migrate and divide enough to fill in that gap. So in that case, if we have a widespread destruction of the stratum germinativum, we often need to get a skin graft in order to repair that skin. The next layer above the stratum germinativum is something called the stratum spinosum. And spinosum here just means spiny. And it consists of about 8 to 10 cell layers of nice living cells. Now you look at them and they don't appear to be really squamous cells, maybe a little bit cuboidal, but remember the whole epidermis is considered stratified squamous because the upper cells are squamous. So here in the spinosum we have 8 to 10 cell layers of living cells, and they're held together by special cellular connections called desmosomes. Now when we preserve this tissue, it creates a spiky appearance in the skin because the cells shrink a little bit, which exposes their desmosomes or intracellular connections. And that's why we call it the stratum spinosum. Once we fix these tissues in formalin and look at them under the microscope, the cells artificially appear spiny, but they aren't really spiny in living skin. So the next layer above the stratum spinosum is the stratum granulosum. And this layer contains 3 to 5 layers of flat cells that are undergoing apoptosis. And apoptosis is just a fancy way of saying programmed cell death. And so the body is programming these cells to die, and as they're dying, they're accumulating keratohyalin granules and also substantial amounts of lipid. And so when they die, they'll be pushed up to the above layers where they will form a nice flat tile-like connection of cells that are very tough and very waterproof. And so again, the stratum granulosum is a transition in the skin. Everything below it is alive and everything above it is dead. And so the stratum granulosum contains 3 to 5 layers of dying cells that are accumulating keratin and also lipids. And so the next layer above the stratum granulosum is the stratum lucidum. And as I said in the previous slide, everything above the stratum granulosum is dead tissue. And that's true for the stratum lucidum. It contains maybe 3 to 5 layers of clear, flat, dead cells, and we call it the stratum lucidum because it looks semi-translucent, just like a window. Now it's important to point out that the stratum lucidum is not found in all skin, but it is only found in thick skin. That is the skin on the palms of your hands and the soles of your feet. And the final layer of the epidermis is the stratum corneum. The stratum corneum is the most superficial of the strata, and it consists of 25 to 30 cell layers of flat, dead cells that contain a lot of keratin. And these cells are continuously shed. If you're ever in a dark room with a shaft of light going through there, and you see the little flecks of things going up through the shaft of light, think about what those flecks of things are. They're dead skin cells. And in fact, you're losing hundreds of thousands of dead skin cells every hour. And you shed somewhere about 30 to 40 pounds of dead skin cells in your life. And so there's a lot of turnover going on here in the stratum corneum. And this continuous shedding of epithelial cells is one way to prevent bacteria and fungi from getting a hold on the skin and invading deeper regions of the body. It's also a very effective barrier to light, heat, water, and most chemicals. And this is because it contains lamellar granules which contain both keratin and also lipid that make it tough and watertight. Now it's important to point out that even though the stratum corneum is dead, if it's exposed to constant friction, it will actually thicken and harden in response to this friction. And so this is what we call a callus. For example, if you walk around barefoot a lot of the time, you'll get calluses on the bottom of your feet. If you play guitar or a musical instrument, you may get calluses on your hands or fingertips. And so these calluses are just thickenings of the stratum corneum. So I mentioned a couple of slides back something about thick skin and thin skin, so I want to go back to explain the difference between these two skin types. First of all, let's start with thick skin. Thick skin is found on the palms of the hands and the soles of the feet. So we call it thick skin because it has that additional layer called the stratum lucidum, and it tends to be thicker than the thin skin that we find over most parts of the body. Now, in addition to having stratum lucidum, the thick skin lacks hair follicles and also erector pili muscles, and so it's not possible for you, for example, to grow hair on the palms of your hands or the soles of your feet. It also lacks sebaceous glands, but it does have a lot of eccrine sweat glands, and we'll talk about the functions of those in just a minute. On the other hand, thin skin is found everywhere else in the body. That is, everywhere else except for the palms of the hands and the soles of the feet. And so thin skin, of course, can have hair follicles. It doesn't have a stratum lucidum, and it also doesn't have fingerprints called epidermal ridges, which are present on both the feet and the hands. The last thing is that thin skin has a sparser distribution of sensory receptors than thick skin. And that's why if you poke yourself, let's say in the arm with a needle versus the fingertip, it tends to be a lot more painful on the fingertip because thick skin has more sensory receptors. Now that we've talked about the epidermis, we're going to go on to talk about the dermis. So the dermis is the layer beneath the epidermis, and the dermis is composed of connective tissue. There are two different regions of the dermis, the upper papillary region and the lower reticular region. So let's take a look first at the papillary layer. Remember, the word papillae means bump or nipple-like projection, and so here in this slide you can see the bumps that unite the papillary layer to the overlying epidermal layer. Now the papillary layer is composed of a loose fibrous connective tissue, otherwise known as areolar tissue. And so the dermal papillae have two functions. First, they have lots of blood vessels in them, and these blood vessels are very important because they are the closest nutrient source for all the epithelial tissue that's in the epidermis. Remember, epithelial tissue does not have a blood supply, and so all the nutrients have to diffuse from the blood vessels in the dermal papilla up to the epithelial tissue in the epidermis. The other function of the dermal papillae is they help to hold the epidermis to the dermis. If you take a look at the picture at right, you can see that there's almost a tongue and groove type of architecture going on here. And this helps to prevent shearing of the epidermis from the dermis due to friction. However, this sometimes still occurs even though we have this tongue and groove formation. If you've ever had a blister, you've noticed that that fluid accumulates between two layers of the skin. The layer of skin on top of that blister is actually epithelial tissue, or epidermis, and the layer of skin underneath that tissue is going to be your dermis, made of connective tissue. And so sometimes these two layers will separate if they're exposed to large amounts of friction. Now, in areas of the body where we have thick skin, for example, palms of the hands, soles of the feet, these dermal papillae will line up into lines forming something called friction ridges. And these friction ridges are the basis for our fingerprints and, well, I guess you call them our toe prints. And the purpose of these friction ridges is there to help us to grasp a hold of things. For example, grasping things with your hands, and also gives you better traction if you're walking around barefoot. Now, another function which didn't really evolve this way is that they can be used to identify people. We tend to have different fingerprint patterns on each person, and this is determined in part by genetics and also in part by human development. And so these friction ridges serve a dual purpose, both for helping us grasp things and also forensically for identification. So the layer below the papillary layer is called the reticular layer, and the reticular dermis is composed of dense, irregular, fibrous connective tissue. Remember that dense, irregular, fibrous connective tissue has fibers that are going every which direction, and they tend to be very thick fibers, and this makes skin fairly strong no matter which direction you pull it in. However, there is an order to the fibers that more of them tend to go in one direction to the other, which leads to tension lines and also lines of cleavage. Another thing I should point out about the reticular region of the dermis is, just like the papillary region, there are blood vessels here as well as sensory receptors. So now we're going to take a look at a photograph of a histological section through the skin and see if we can identify the different layers we've learned so far. So if you take a look at the red arrow, what layer do you think that is? Well, the correct answer here is this is the stratum corneum of the epidermis. Remember, the stratum corneum contained dead, flattened epithelial cells in about 25 or 30 different layers. Now below that, the blue arrow shows the papillary region of the dermis. Remember, the papillary region contains areolar connective tissue, which contain blood vessels and also sensory receptors as well. And finally, the green arrowhead here indicates the reticular dermis, which is composed of dense, irregular, fibrous connective tissue. And remember, this is connective tissue where the fibers were oriented in all different directions. And so the connective tissue layers, that is the papillary layer and the reticular layer, contain blood vessels and also sensory receptors, whereas the epithelial cell layer contains sensory receptors but no blood vessels. All the nutrients that supply the epithelial layer have to come from the underlying connective tissue layers. Now, the third layer we're going to talk about here is the hypodermis. Remember, hypo means below, and dermis here referring to the skin. And so I should remind you that the hypodermis is not technically part of the skin as defined by the authors of your textbook and indeed most anatomists. However, we are going to cover it here because it is found just underneath the skin. And so the hypodermis, or subcutaneous layer, is composed chiefly of adipose tissue and also areolar tissue. Just like the dermis, we have lots of blood vessels here. We also have lymphatic vessels and lots of nerves and sensory receptors. And so we have special receptors that sense deep pressure. Think about how deep the adipose part of the skin is. It's fairly deep. And so if you were going to push down on your skin, you'd have to push fairly hard to activate the sensory receptors that are in the hypodermis. Now, I should also point out that the fibers of the hypodermis are continuous with those that are in the dermis. So these two areas of the skin really aren't that separated. But there's enough separation and enough sponginess within the hypodermis that it gives us a nice flexibility of our skin, that it's not directly attached to the underlying tissues, for example, muscle and bone. And so if you've ever given somebody a rug burn on their arm, you can see that you can move the overlying skin layers, the dermis and the epithelial tissue, pretty easily while the underlying structures remain in place. And in part, the suppleness of the skin is due to the fact that we have this nice fatty layer between the muscle and the overlying dermis and epidermis, and that fatty layer is called the hypodermis. So here's another histological section through the skin showing now all three layers. We have the epidermis up top, which is made up of stratified squamous epithelium, the dermis in the middle, which is composed of areolar tissue and the papillary layer, and also dense irregular fibrous connective tissue in the reticular layer. And finally, down deep, we have the hypodermis. Remember, the hypodermis was chiefly made up of adipocytes or fat tissue and also lots of areolar connective tissue. Okay, now we're going to talk about some of the accessory structures of the skin, and these develop from the embryonic epidermis. That is, they're composed initially of epithelial tissue. And the accessory structures we're going to talk about include things such as hair, the oil glands or sebaceous glands, sweat glands, and also nails. So hairs or pilli are present on most skin surfaces except for this thick skin found on the palms of the hands and also the soles of the feet. And as you might imagine, hair initially evolved in mammals as a thermal barrier. That is, it helped mammals conserve body heat by holding it close to the body. However, if you look at humans, as hairy as we may be, we probably don't have enough hair to really hang on to a whole lot of body heat. The only exception here is, of course, the hairs on the scalp of the head. There's enough there that it tends to reduce heat loss in the scalp. I can tell you, if you've ever shaved your head, your scalp gets a lot cooler a lot faster without that hair there. The other function that hair does for us is that it helps to absorb a little bit of the UV energy and prevent that UV energy from getting to the skin. Again, this is particularly true for the scalp, which is pretty well covered with hair. Now, hair consists of two main parts. The part of the hair that is visible to the naked eye is called the shaft, and the shaft is the hair that is above the skin surface. And it's important to point out this shaft consists of entirely dead tissue. So the hair that is visible on your scalp and on your arms and elsewhere in your body is completely dead. It doesn't need nutrition like the people advertise on the different shampoo commercials. Now, that being said, hair does look a little bit better if you wash it frequently and if you condition it, but in the same way that leather looks better when you wash it and you condition it frequently. That leather's not alive, and by the same token, the hair that's on the outside of your body is not alive either, and so it's not going to absorb nutrients in the same way that living tissue would. Now, the living part of the hair is located underneath the skin, and this includes the hair root. The hair root is where active cell proliferation is going on and where keratinization is ongoing. Keratinization, again, is just the process of accumulating that tough, fibrous, waterproof protein within the cells that are going to make up the hair. Now, if we take a look at a hair that we plucked from somebody's head, we can see up to 3 different layers. On the very inside, we see something called the medulla. The medulla of hair is made of something called soft keratin, and it may also have air spaces and be associated with certain amounts of pigment. For example, the hair you see at right would be from somebody with brown hair. Now, just outside the medulla is something called the cortex. The cortex is composed of dense keratin or thick keratin, and it surrounds the medulla. And finally, outside the cortex, we find something called the cuticle. Now, the cuticle is a single layer of cells. That is a simple layer of cells that's surrounding the rest of the hair. And the cuticle is the part of the hair that becomes most damaged due to drying out. And so if you see people that have split ends or frayed ends, most oftentimes this is because the cuticle cells are starting to peel away from the cortex of the hair. And of course, we can treat this with conditioning products, many of which contain fats and lipids that help to basically adhere the cuticle back to the cortex of the hair. And of course, you probably already know that hairs are produced in hair follicles. But what you might not know is that a follicle is a specific term that we're going to see again and again in this class. Specifically, a follicle is a sac of epithelial tissue that is secreting something. And we have hair follicles, but we also have follicles within the ovaries, which secrete different types of hormones, for example, estrogen and progesterone. We also have follicles within the thyroid gland, which secrete thyroglobulin. So anytime you hear the word follicle, just think it's a sac of epithelial tissue that is secreting something. So glandular epithelial tissue makes up a follicle. And so hair follicles are the structures that produce hair, and they start out on the epidermis, but they extend very deep into the dermis by about 4 to 5 millimeters, so they can be quite deep. And the parts of the hair include the hair root papillae, and this is where the blood vessels are located and the most active cell division is going on. Now, on the outside of that, we have a peripheral connective tissue sheath, and beneath that, an inner epithelial sheath that makes up the walls of the hair follicle. And finally, we have something called the hair matrix, which again is actively dividing cells that are giving rise to this hair. Now there are a suite of accessory structures that are associated with the hair or hair follicles. And the first of these is something called the erector pili muscle. And remember that pili here means hair, and erector is something that is going to stand that hair up straight. And so the erector pili muscle is composed of smooth muscle, and it basically connects the base of the hair to the surface of the skin. And when this muscle contracts, it causes the hair to stand up. And if you remember back to smooth muscle, you should remember that we cannot control it voluntarily. And so this smooth muscle contracts through a reflex, either because we've become scared or because we are cold. Now, because we don't have much hair, the erector pili reflex doesn't serve much purpose for humans, but if you take a look at other mammals, for example cats, the erector pili reflex is very spectacular. So if you've ever walked across a cat and all of a sudden startled it, you'll notice that the hair will stand up straight on its ends, and it will help to make that animal look a lot bigger. And to a potential predator, this might dissuade them from attacking this animal because all of a sudden it looks, a third bigger than it normally did. And so the erector pili reflex can be a defense mechanism in some mammals. Now the other thing associated with the hair or hair follicle is something called the hair root plexus. And the hair root plexus is basically a network of nervous tissue that surrounds the base of the hair follicle. And this is one reason why plucking hairs can be very painful. But the real purpose for the hair root plexus is to sense any vibration or movement that comes through the hairs. Now remember, the hair shaft itself and all the hair parts that are exposed above the skin are dead. However, they are connected to the hair root plexus below the skin. And so let's say if an insect lands on your hair or a spider or something like that, we can actually feel that movement in our hair because it vibrates or moves our hair root plexus. Now, one thing I should point out before we move on is that there's two different types of hair. Vellus hair is the very soft, downy hair that you have when you're born, and many females also continue to have vellus hair as adults, whereas terminal hair is a hair that becomes coarser and darker in response to hormones, usually androgens. And so thinking about the differences between vellus hair and terminal hair, think about what your hair looked like when you were, let's say, 4 or 5 years old. You probably have some pictures if you don't remember it. My hair was this sort of white to golden yellow, and I looked like, I don't know, that little girl from the Poltergeist movie. It was just almost white. And then over the next series of years, that hair got a little bit darker, it got a little bit coarser, and by the time I finished high school, my hair got pretty darn brown. It was no longer blonde, but it was brown and also a lot thicker and a lot coarser. And this was what we call terminal hair, and it had changed because of the exposure to testosterone. So both estrogen and testosterone have an effect on the pigment of the hair and also on the thickness or coarseness of hair. Now, you've heard of alopecia, which is not having enough hair, that is hair loss, but we can also have too much hair. And hirsutism is basically the state of having excessive amounts of body hair. So if you're down in Waikiki and you're on the beach and you're wondering, why is that guy wearing a sweater on the beach? And all of a sudden you realize, that's not a sweater. That is somebody that is suffering from hirsutism. And hirsutism is, again, excessive hair production, and it can be a result partially of genetics and ethnicity, but also of oversecretion of certain types of hormones, that is, androgens. And so as you probably know, there's no real simple treatment for hirsutism. You can shave that hair, but it comes back in a few days. We can pluck the hair, but that comes back in a couple weeks. And then we can use depilatories, for example, Nair, that dissolves the hair shaft but leaves the hair matrix intact. Or we can do something more permanent like electrolysis, where we actually generate an electrical current which will basically burn or fry the hair root matrix and the hair follicle and prevent that hair from regrowing. Unfortunately, because it usually involves several treatments, electrolysis is very time-consuming and also quite expensive. Another accessory structure associated with hair follicles is something called a sebaceous gland. A sebaceous gland is basically an oil gland. That is, it produces an oily-like secretion which lubricates our skin surface and also gives a nice sheen to our hair. And so the sebaceous glands themselves are extensions of epithelial tissue from the epidermis that extend way down into the dermis. And most of these glands have a single duct that empties into a hair follicle. And the sebum here is composed primarily of glycerides and also fatty acids. And so the purpose here is to trap moisture, keep hair soft and luxuriant, and it also helps to reduce the risk of infection in the skin. There are some antimicrobial properties about sebum. The last thing you should know about sebaceous glands is they are holocrine glands. And remember, holocrine glands are epithelial glands where the whole cell accumulates a secretion and then bursts to become part of that secretion. And so, as you might imagine, there has to be a very high rate of mitotic cell division within sebaceous glands in order to make sure that we produce more and more sebum. Now, as you can see right now, that sebum can get trapped underneath the skin and cause a bump and also some inflammation. So we call the bump that we see of sebum underneath the skin a comedo, or a whitehead. Now, if you accumulate excessive amounts of sebum in your pores, you also probably know that you may be at risk for acne. And acne is a type of inflammation and sometimes infection that result of overproduction of sebum. One thing I forgot to mention in the last slide is our production of sebum is governed by our hormones. And that's why acne tends to appear around the time of puberty. And that's because we have this surge in sebum production, which is stimulated by estrogen or testosterone. And the excessive amounts of sebum can cause inflammation and pustules that we know as acne. And acne is not only socially scarring, but can be physically scarring as well. And that's why it's probably a good idea to get treated with various topicals. For example, Retin A is a topical that you can use, also benzoyl peroxide products, but they also have the big guns that use to treat the cystic acne, which are drugs like Accutane. Now, Accutane is an effective treatment for acne because it dries up the secretions of sebum from the sebaceous glands. However, just like many drugs, it also has some pretty undesirable side effects. It has a high incidence of causing birth defects, and so women that are on this medication have to make sure they're taking 2 different forms of birth control to ensure that they're not going to get pregnant. The other thing is that because Accutane interferes with the production of the triglyceride or sebum within the sebaceous glands, it may also have an effect on liver function. So people on Accutane typically have to go in to get their triglycerides and liver enzymes tested every couple months. Finally, another type of gland that we have on the surface of our skin is something called a sudoriferous or sweat gland. Sweat glands are found all over the body, and there's 2 different types of sweat glands. The first of these is eccrine sweat glands, which are found pretty much everywhere. And eccrine sweat glands have a duct that empties onto the skin surface, usually not into a hair follicle. And eccrine sweat glands produce a sweat that is very watery, about 98% water, contains a little bit of dissolved ions, for example, sodium ions, chloride ions, also contains the urea, a little bit of ammonia, but it tends to be a very watery secretion. On the other hand, apocrine or apocrine sweat glands are just found in the groin and also in the armpits. And they tend to empty directly into a hair follicle rather than emptying on the skin surface. And the secretions of apocrine sweat glands tend to be a lot thicker, a lot fattier than those of eccrine sweat glands. And initially, these secretions are odorless. They have no odor, but because they have lots of nutrients in there, they are very quickly infected with bacteria that break them down and produce some very characteristic smells of the nether regions of the body. And so here in America, we try to cover up that scent. We wear deodorant, we bathe regularly, but in truth, some of that smell that is produced by the breakdown of apocrine secretions may in fact be some form of human pheromone. And a pheromone is just basically a type of substance that is produced by one gender that can be sensed by the other to help gauge the reproductive status and also receptivity of that individual. Another type of gland that we have within the ear is something called a ceruminous gland. A ceruminous gland is a modified sudoriferous gland or sweat gland that produces wax, and the name for wax here is cerumen. And cerumen is found and produced in the external auditory meatus, that is the external part of the ear. And it is a very sticky, waxy barrier that prevents the entrance of foreign bodies, for example, insects, bacteria, and the like. And of course, you probably already know that earwax or cerumen can build up within the external ear, and sometimes you have to have them professionally cleaned, or if you're one of those people like me that actually use Q-tips in the ear, you just have to be very, very careful about pulling it out so that you don't accidentally damage the eardrum or tympanic membrane. Okay, our next accessory structure of skin are the fingernails and toenails, and nails are scale-like modifications of the epidermis, that is, they're derived from epithelial tissue. And in animals, we call these hooves or claws, and they're also very similar. And they're basically a protective covering for the distal phalanges and the dorsal surface of the phalanges, that is, the fingers and toes. and they contain hard keratin much in the way that the outer surface of the hair does. And hard keratin, as the name implies, is much harder and tougher than the soft keratin that we find in skin. And the nails are generated in an area called the nail matrix, which is located just proximal to the eponychium, otherwise known as the cuticle. So here you can see a picture of the fingernail both in a dorsal view and also in a sagittal view. And so remember, the eponychium or cuticle is the area behind which the nail matrix exists, and the nail matrix is where the new nail bed is laid down. And the white area just distal to that is called the lunule, and this is the semicircle region of white that you see just below the cuticle. At the distal edge of the fingernail, we see something called the free edge, otherwise known as the hyponychium. And hypo, remember, means below. And the hyponychium is the area of your fingernails that tends to accumulate dust and grime and dirt and things like that. And of course, no discussion of skin or the integumentary system would be complete without a discussion of skin cancer. And this is especially true in Hawaii, where about 1 in 5 of us will come down with skin cancer at some point in our lives. Now, most skin tumors are benign and do not metastasize or spread throughout the body. And we tend to call tumors neoplasms. So a neoplasia is any type of new growth, and it can include things like warts, but also cancerous tumors. Now, the risk factors for skin cancer, of course, include overexposure to UV radiation. This is number 1. The other thing is if you have very light skin pigment, you're predisposed to skin cancer. And also, if you have frequent irritation of the skin, you may also be predisposed to skin cancer. Now, of course, the one way to prevent overexposure to UV radiation is to stay out of the sun and use the highest SPF sunscreen that is practically possible. Now, more recently in the news, you've probably seen where some sunscreens have actually been implicated in increasing the rates of certain types of tumors. On the other hand, there's other types of sunscreens that work at a molecular level and tend to reverse some of the damage that's done by UV radiation to the DNA inside of cells. So the 3 major types of tumors that we're going to talk about today include the basal cell carcinoma, the squamous cell carcinoma, and also the melanoma. In case you're wondering, a carcinoma is just a cancer or tumor of epithelial tissue. So the most common and most benign type of carcinoma is called a basal cell carcinoma. And this type of cancer starts with the stratum basale. These are the cells that were sitting on the basement membrane and rapidly dividing to give rise to the cells above. Now, contrary to what you might expect for cells that are rapidly dividing, the stratum basale cells have a low propensity to invade the dermis and hypodermis, that is, a low propensity to metastasize. In most cases, the tumor can be detected visually long before metastasis occurs, and in many cases, we can surgically excise that tumor and have a very low risk of metastasis outside the area. So over 99% of surgical treatments for basal cell carcinoma are successful. Now, the second most common type of skin cancer is called squamous cell carcinoma, and this involves the keratinocytes that are located in the stratum spinosum. Squamous cell carcinomas are usually very scaly and reddened in appearance, and they tend to occur most frequently on the scalp, the ears, the lower lip, and also the hands. Now, unlike basal cell carcinoma, these do have a higher potential to metastasize or spread out of the immediate region. However, the patient will have a good prognosis if the tumor is detected early and treated by a radiation therapy or removed surgically. Now, the rarest of the skin cancers, but the most deadly form, is called a melanoma, and melanomas account for less than 2% of skin cancers. As the name implies, this is a cancer involving the melanocytes, and of course it is the most dangerous cancer because it is highly metastatic. That is, it tends to spread very readily from the area where the tumor was created to distant areas of the body. Now, melanomas are also highly resistant to chemotherapy, and because they spread rapidly, surgical excision may not completely remove all the tissue. The key to survival for melanomas is, in fact, early detection, and that's where something called the ABCD rule comes in. The ABCD rule is a rule that can be used to evaluate a potential lesion or dark spot on the skin to see whether it has a likelihood to become cancerous. And the A here stands for asymmetry, that is, irregularity in the shape and size of the tumor or the spot. If the two sides are identical, that is mirror images of them, there's a less likelihood that this is in fact going to be a melanoma. On the other hand, if one side of a lesion is much different in shape than the other side, then there's a good chance this may be a melanoma. The B in ABCD stands for border irregularity. If we see a nice smooth circular border, again, low chance for melanoma or metastasis. On the other hand, if we see a border that exhibits indentations or irregularities, then we are starting to worry more and more that this may be a melanoma. The C stands for color. Normal moles and nevuses are uniform brown in coloration. On the other hand, a melanoma tends to blend several colors. We tend to see blacks blended with browns, blended with tan, and sometimes red or blue. So if you see a lesion or a mole that's multicolored and has irregular borders, this is something that you want to bring to the attention of your general practitioner or your dermatologist. And finally, the D here stands for diameter. If we have a lesion or a mole that's greater than 6 millimeters in diameter, which is about the size of a pencil eraser, you want to let your healthcare professionals know and get that lesion biopsied or at least examined by somebody that's competent enough to do a good skin exam to make sure that you don't have a melanoma. Again, the trick with melanoma is early detection is going to make for a better prognosis and a greater likelihood of cure. Now we're going to switch gears a little bit and talk about burns to the skin. Now, because the skin is the outer barrier of our body, it is prone to being burned either by UV radiation, by heat, electricity, and certain chemicals. And burns, regardless of the source, tend to denature the proteins in skin and also kill the living cells that make up skin. Now, severe burns can actually pose two different threats to life and limb. The first is the most immediate threat. If we have a severe burn that affects a large proportion of the body, this can lead to dehydration and fluid loss and electrolyte imbalance that can lead to hypotension, shock, and immediate death. And so one of the treatments for somebody that has a massive burn is, of course, going to get them on IV fluids to prevent renal shutdown, which is shutdown of the kidneys. Now, to evaluate burns, we have something called the rule of nines, which basically divides the body into 11 different areas, each of which is afforded 9%. And so it's a way to evaluate how much of the area has been damaged by burns, and therefore how much fluid needs to be replaced in the body. So this slide just shows a diagram depicting how we can use the rule of nines to estimate the amount of skin that's been affected by burns throughout the body. Now, we tend to divide things into 11 different regions, and these regions include the head, the trunk, the left and right arms, the legs, and also the genital region. So starting out with the head, we give the entire head 9% of the body. So if the front of the head has been burned, let's say the face, that's 4.5%, whereas if the back of the head has also been burned, that's an additional 4.5% or 9%. Now let's move down to the trunk of the body. The anterior trunk is actually 2 times 9%, so 18% for the front and also 18% for the back. So that gives the trunk a total of 36%. Now let's take a look at the arms. The anterior arms are 4.5% apiece, or 9% for the anterior region, and there's also 4.5% apiece for the posterior region for a total of 9%. So the arms altogether compose about 18% of the surface of the body. Now let's look at the legs. Legs are much larger than arms, so both the anterior and posterior surfaces of the legs are worth 9%. That is, the anterior left leg is 9%, and the anterior right leg is 9%. The posterior left leg is 9%, and the posterior right leg is 9%. So altogether, the legs are about 36% of the skin area on the body. If you add all these percentages up, you see they equal 100%. So we classify burns based on the number of layers that are affected. For example, a partial thickness burn is sometimes called a first-degree burn. And we call this a first-degree burn because it only affects the epidermal region. And so a good example of a first-degree burn would be a very bad sunburn where you have some peeling and things like that, but the underlying layers are not affected. Now, on the other hand, a second-degree burn involves both the epidermis and the upper region of the dermis. And here's where we get blistering and also shedding of skin. Lastly, a full thickness burn is also called a third-degree burn, and this involves the entire thickness of the skin, including the epidermis and the upper and lower regions of the dermis. It may even affect the hypodermis. Now, unlike the other two burns, which can be quite painful, a third-degree burn is usually not painful because the nervous tissue is completely destroyed. The skin of these individuals will look gray-white in appearance to cherry red or blackened, depending on the amount of underlying tissues that are exposed or damaged. In most cases, in order to repair a third-degree burn, we'll need to graft skin from other areas of the body because the stratum germinativum and the underlying connective tissue have been completely destroyed. So this slide just shows examples of each of the 3 types of burns. Up in the top left-hand corner, you can see examples of first-degree burn where somebody has some erythema, some redness of the skin that is a result of heat-induced burn. Lower down on the palmar region, you can see where they have a second-degree burn, which has resulted in blistering, and that's going to result in some tissue loss. And then finally, on the right-hand side, we can see a third-degree burn. The epidermis has been burned away, as is most of the dermis, and we can just see the underlying tissue exposed. And as it was saying in the previous slide, third-degree burns, even though they have the worst prognosis, they're probably the least painful because so much of the tissue has been destroyed that the nervous tissue responsible for transducing that pain has been destroyed. And so usually the patient is not going to feel any pain as a result of that third-degree burn. Now, as we said a while back, burns can be bad for two reasons. One, because if we have a large area of the body that's burned, that can initially lead to dehydration and also throw off our ionic balance, leading to multi-organ failure. Now, the more delayed worry is that after that initial period has gone by, say 24, 48 hours, we now risk infection. Because remember, the skin was the barrier between the inside of our bodies and the external environment. And so studies have shown that even after it's burned, skin can remain somewhat sterile for about 24 hours. But after that, it starts to be inhabited by bacteria and fungi that can quickly move into the dermis and cause a systemic infection. So burns can be particularly critical if they involve greater than 25% of the body in terms of a second-degree burn, or greater than 10% of the body if we have third-degree burns. Now, critical areas of the body include the face, hands, and feet. If we have third-degree burns on these areas, we want to be very, very careful in treating and evaluating these patients. Now, treatment for second and third degree burns may include debridement, that is removal of dead or necrotic skin, and this can involve some pretty painful procedures where they go in with a brush and basically brush out a wound several times a day to remove all the necrotic tissue so that they can place on a skin graft or bandage that area. But again, the debridement process can be kind of painful. Now, of course, you're also going to give these people massive amounts of antibiotics to ward off any infection that can occur while the cutaneous membrane has been compromised. We may even give them a temporary covering of, let's say, artificial skin for the time until they can generate a new epithelial layer and also a new underlying dermis layer. And a third option here is to actually give them skin grafts. Now, we can go from another patient, allografts, or we can go from the same patient but a different area of the body, and these are called autografts. Now we're going to wrap up this lecture in talking about wound healing. And wound healing can be divided into either shallow wound healing that involves the epidermis or deep wound healing that involves both the epidermis, dermis, and maybe even the hypodermis. So let's start out with epidermal wound healing. So let's say that you're in the office and you're using a paper cutter and somehow you get a cut on your skin that goes down and it's very painful, but it doesn't draw any blood. Now, because it doesn't draw any blood, it's probably only in the epidermal area. And so we have an abrasion or a very shallow cut that we need to heal, and we do that through the process of regeneration. So take a look at the picture at the bottom left. Here you can see that we have a cleft or a cut through the epithelial layer or the epidermis. Now, the way that we are going to heal that cut is we're going to have lateral migration of our basal cells along the basement membrane. Now, once those basal cells migrate, they're going to start dividing and dividing and dividing and dividing and dividing until we get a nice thick layer above them of stratum spinosum and eventually stratum granulosum. So eventually we can replace the full thickness of the epithelial tissue and have no signs that a lesion or cut was ever present. Now, it's important that I point out that the growth of epithelial cells is governed by the secretion of epidermal growth factor. Epidermal growth factor, or EGF, helps to stimulate the growth and turnover of epithelial cells. Now let's take a look at deep wound healing. A deep wound is a wound that involves not just the epidermis, but also the dermis and possibly even the hypodermis. And so here, healing will occur in 4 phases: the inflammatory phase, the organization or migratory phase, the regenerative or proliferative phase, and finally the maturation phase. So let's start out with the inflammatory phase. You've gotten a very deep cut, and that cut is bleeding, indicating that it's gone down to the dermis. Now, the first thing you're going to notice is there's going to be a lot of blood. The blood, of course, is eventually going to clot to form a scab or a blood clot. And around that same time, you'll also notice the surrounding area of the tissue becomes reddened and engorged with fluid. And this is because inflammation's going on. And remember, inflammation is stimulated when tissue is damaged. And inflammation has good factors and bad factors here. One of the good things about inflammation is it helps to bring our white blood cells to the area of the injury. And white blood cells are very important for scavenging up the dead and dying cells and also removing any bacteria or other pathogens that may have contaminated the wound. The other thing that inflammation does is it helps to bring raw materials to the site of the injury so that repair can happen more quickly. Now, during the organization phase, we are going to restore the blood supply that was compromised during the initial injury. And so during this time, we're going to have a blood clot replaced by something called granulation tissue. And granulation tissue is basically a type of connective tissue, and we call it granulation tissue because it's pink and it has these little nodules on there that are basically the capillaries. There's lots of capillaries in here that bleed very easily, and the purpose of this granulation tissue is to restore the blood flow and help unite the damaged edges of the connective tissue. Now, it's important to point out that this granulation tissue will eventually become scar tissue. It contains lots of fibroblasts, and the job of these fibroblasts is to weave fibers in between the two separated areas of the wound, that is, the areas in the dermis, maybe even hypodermis. Now, I should point out that the tissue that we use to do that is not like the tissue that was there before, and that's why scars are often very conspicuous, because they're composed of a different type of fiber woven in a different type of direction. Now, once we close the deep margins of the wound using our fibroblasts, the next step that's going to go on is something called regeneration. And regeneration can also be called the proliferative phase because it results in the completion of tissue healing. And here's where we have our epithelial cells, again, migrating laterally underneath the blood clot, which will become a scab, and as they begin to divide, they will move further and further up, creating additional layers above them. That is more and more stratum spinosum, granulosum, and eventually stratum corneum. Now, this stage of maturation happens when we have a full thickness replacement of the entire epidermal region, and then the blood clot or scab will fall off. You now reach the end of the lecture on the integumentary system. Just like every other week, we're going to have a brief pre-quiz at the end of the chapter, and so there will be about 10 or 15 questions that deal with the integumentary system. Now, you won't be graded on these questions, but if you score less than 70%, I do suggest you go back and rewatch the lecture again, take more detailed notes before you go on to take this week's La Lima quiz.